good afternoon, everyone, and welcome to the second annual CMRG review of the annual ASH meeting and Exposition. I'm Donna Reece from Princess Margaret Cancer Center and Chief Medical Officer of CMRG. For those of you who are unfamiliar with our organization, CMRG is the national research group involving myeloma physicians and medical centers from coast to coast. We have two main thrusts. One is our growing national myeloma database, which has almost 8,000 patients entered into it. But our main goal is to deliver the best new treatments to myeloma patients as soon as possible, given the delays in regulatory approval and provincial funding. This year's ASH contained many exciting new abstracts, but we've decided on a somewhat different format this year in that rather than an encyclopedic review, we picked 10 abstracts that have direct relevance to the Canadian landscape. There will be a presenter for each of these abstracts, a commentary by my co-chair, Dr. Arleigh McCurdy or I, and we will have to go at a fast clip to get these presented within the hour and allow a bit of time for questions from the audience again at the end. So I will then turn it over to our first speaker, who is Dr. Julie Stakiw.
Thanks, Donna. So I'm Julie Stakiw. I'm a hematologist in Saskatoon at the Saskatoon Cancer Center. And the first abstract I'll present is an updated analysis of the Griffin trial after 24 months of maintenance. Next slide, please. Hopefully we're all familiar with the Griffin trial by now, which is a phase 2 randomized study looking at the addition of daratumumab to the RVD backbone in induction and then a transplant, followed by consolidation with the addition of daratumumab to BRD versus BRD alone, and then actually 2 years of maintenance with either daratumumab added to lenalidomide or lenalidomide alone. The endpoints, as you can see on the right, were the stringent CR rate by the end of consolidation, and then there were secondary endpoints, the usual players, rates of MRD negativity, and some of the overall response rates. Next slide, please. So just in terms of patient disposition, all of the patients either completed 2 years of maintenance therapy or discontinued the study treatment, and the median follow-up was 38.6 months. There was a similar proportion of patients who discontinued during the maintenance treatment, either with DR or R alone, and you can see some of the reasons there for discontinuing therapy. Next slide, please. So as we have expected, but it's very nice to see that the results certainly seem to deepen over time from induction to transplant to consolidation. Last year, the results after 1 year of maintenance was presented, and you can see here that truly after 2 years of maintenance, the results have continued to deepen over time. The purple being the addition of daratumumab with a CR or better, adding up to 82%, with just the lenalidomide maintenance alone being 61%. Next slide, please. Also important is the depth of response including MRD negativity. And you can see here that depth of response continued as you progressed all the way through, even up until the after 2 years of maintenance. So again, if you look at 10 to minus 5 with the addition of daratumumab, you certainly get a very nice addition of individuals who are MRD negative after 1 year of maintenance, and then even further after 2 years of maintenance compared to just lenalidomide maintenance on its own. Next slide, please. So just in conclusion, certainly we see rates of sustained MRD negativity higher for the addition of daratumumab and superior MRD negativity. And while I didn't show, certainly in the presentation, it was across all subgroups, including patients with high-risk features. The study wasn't powered to show a progression-free survival benefit, but there did look to be a trend toward improved progression-free survival beyond 1 year of maintenance. And certainly the addition of daratumumab to 2 years of maintenance was well tolerated overall. From my opinion, certainly this provides additional evidence that the addition of an anti-CD38, and in this case daratumumab, to upfront treatment does provide significant benefit. If you continue to add daratumumab throughout the different pieces of treatment in the transplant-eligible, newly diagnosed multiple myeloma setting, you have ongoing benefit. And I do question whether this will become a new standard of care in Canada. Now I'll pass it over to Michael.
Hi, everyone. I'm Michael Sebag. Thank you, Julie, for that presentation. I'm nowhere near going to do such a good job. So I'm presenting a GMM7 trial that looks at the addition of isatuximab, so a competitor to daratumumab, an anti-CD38 antibody, to lenalidomide, bortezomib, and dexamethasone as an induction therapy for newly diagnosed transplant-eligible myeloma. It's a phase 3 trial. And really the background is to maximize treatment response and depth of response. And there's really 3 ways to do this, as Dr. Stakiw has eloquently pointed out. You can do it in the pre-transplant induction regimen. You can change around your transplant conditioning regimen, or you could do something in the post-transplant setting in consolidation or maintenance. And so this particular trial really, at least this phase of the trial, looks at the pre-transplant induction regimen. Next slide. So here's the schema of the trial. And again, the trial is newly diagnosed myeloma that are transplant eligible. And they're randomized 1-to-1 to either of 2 arms. The standard of care would be lenalidomide, bortezomib, and dexamethasone that you see on the bottom. And the experimental arm would be the same, plus isatuximab. The cycles are 6 weeks, and there are 3 6-week cycles. I don't show you the dose densities in this slide just to save a bit of time, but you can look that up later. This is followed by a autologous stem cell transplantation, and then a second randomization that randomizes to either of 2 maintenance strategies, either our classic lenalidomide as a single agent, or lenalidomide with, again, the CD38 antibody isatuximab. So for this particular, so VRD has become our de facto standard of care, although I understand that in Canada it's not available freely. And the addition of the CD38 antibody is to try and improve on that de facto standard. Now, the primary endpoint of this particular portion of the study that's being presented here, and keep in mind this isn't the entire study, is really what the responses are after that induction regimen. And the induction, so the primary endpoint here is MRD negativity by next generation flow at 10 to the minus 6. And it's stratified according to RISS staging. Now, the secondary endpoints are your complete remission rates, excuse me, after that induction, and obviously safety. Next slide. So these are the baseline patient characteristics, and you can see a pretty standard, about 60 years of age in both arms of the study. And getting to that stratification, we can see that in terms of high-risk patients, there were roughly 20% in both arms that were identified as high risk. And plugging that into the RISS formula, we get RISS3 of about 8% in both arms, the majority being RISS2 patients. Next. So here are the results. And so the secondary endpoint, again, is the response rate. And we can see that there is really no practical difference in response rates here. The CR rate is identical, whether you add isatuximab or not. I want to point out that it's not clear to me whether or not they did a reflex assay to detect the drug, and therefore may have compromised their CR detection, because there is a difference, statistically different, in the VGPR rate, for example, being higher in the arm in which isatuximab had been added. Now, their primary endpoint was the MRD negativity by next-gen flow at 10 to the minus 5. I apologize. I said 6 earlier. And it reached 50.1%, which their cutoff was 50%. So it reached their endpoint. and is superior to the arm without the anti-CD38 antibody at 35.6%. And again, this is done once at the end of induction. Next slide. So, I'm not sure what this trial actually means at this point. Again, the endpoints are not very validated. A one-time endpoint after induction is not clear to me that it is so important. Obviously, PFS would be much more important, and I'll let it go with that. And
Thank you, Michael. I'm going to provide the first commentary and try to put these abstracts into the Canadian context. And as has been noted, our standard in Canada has mostly been CyBorD, not RRVD, although it's available in some jurisdictions, followed by 1 or 2 transplants, depending on risk factors. We are one of the few countries to have public funding, though, for lenalidomide maintenance, not for 2 or 3 years, but until progression. And there's been a major thrust to continue that in as many patients as possible. And then there are variations for some patients. Now, when we look at our benchmark analysis and large numbers of patients through our CMRG database, you can see that we are still quite competitive in our results historically. If you look at the single transplant with len maintenance, the blue line shows what adding maintenance does to this type of treatment, and it's almost a median of 5 years, which is very similar to reported RVD trials. Survivals are excellent. Even in high-risk patients, when we've looked at these individuals, the historic control for PFS is shown in red. It's very suboptimal, but with 2 transplants and with maintenance, you can see a considerable improvement in PFS, not quite 5 years, but 3 years or more with a reasonable survival. Next slide, please. However, the world has changed, and we know the efficacy of these new CD38 antibodies in the relapse setting and early evidence in first-line settings. And I think it's a very high priority for all of us to get these treatments into first-line treatment. And it's going to take a long time for these phase 3 trials to mature and work their way through Health Canada and provincial funding. So really, clinical trials are the only way to get these drugs to our patients. And we have worked hard to try to bring these trials through CMRG and other mechanisms. One aspect of this trial is also to get minimal residual disease testing in the marrow into our practices since it's not funded. Next slide, please. So what do we have? We are just opening a CMRG trial at 10 sites that adds to our backbone of CyBorD, transplant, and lenalidomide maintenance. Add the CD38 antibody isatuximab, and we will not be stopping maintenance at 2 or 3 years as per our standard. So I think this is a nice way to look at our historical comparisons and bring this treatment into Canada. A number of centers, as shown here, are also doing an industry trial, ARIGA, which looks at patients within 6 months of transplant who are still MRD positive and randomizes them either to lenalidomide maintenance or lenalidomide and subcutaneous daratumumab. Next slide, please. I left out that we will be considering also a use of a bispecific antibody that we'll mention later. So my question to the 2 presenters so far is, in 5 years, do you think stem cell transplant will still be the backbone for transplant eligible or younger myeloma patients?
I'll take a quick crack at that and then pass it back to Michael. Truthfully, yes. I think as much as there's great drugs coming, and I think we want to be able to push them into the earlier lines, my hope is one day transplant will go, but just given the rate that we're funding new drugs in Canada, I think that transplant still has a role to play. I think that it provides a depth of response, and I think the study has shown that. I think that whether you do consolidation or maintenance after is still very important, but I still think in 5 years we will be doing the auto transplant. Michael, what do you think?
I fully agree. I think that the more definitive trials that have looked at transplant deferment or no transplant, like the IFM 209 trial, showed an advantage, at least for PFS, that was clear. I think 50 versus 36 months or so for transplant, and it remains a de facto backbone. I think if it's going to be replaced, it's going to take a lot longer to be replaced. If it's going to be replaced, it's going to be, as Donna, you just mentioned, with the addition of bispecifics or maybe CAR-T. But again, those readouts will take a long time, and certainly longer than 5 years before we're able to see a meaningful readout in which we could say one strategy is better than the other. As well, we have to work on our endpoints. I mean, MRD negativity is nice, but by what means, how frequently, how sustained, what that means is something that obviously needs to be better worked out before we can get an earlier readout and act on results which build in MRD.
Thank you to both of you, and we'll move on to our next topic.
Hello, I'm Dr. Kevin Song. I'm a hematologist at the Vancouver General Hospital, and I'll be presenting abstract number 3782, which is titled Characteristics and Outcomes of Non-Transplanted Patients with Newly Diagnosed Multiple Myeloma Initiating Treatment with Bortezomib, Lenalidomide, and Dexamethasone as Frontline Therapy. This was presented by Dr. Rohan Medikar of Janssen as a poster presentation at the recent ASH meeting. Next slide, please. So the background to this study is that bortezomib, lenalidomide, and dexamethasone, otherwise known as VRD, is one of the standard regimens in transplant-ineligible patients based upon the SWOG 0777 study. This regimen is also available in general across Canada. Now, we use this regimen based upon the study, but there is limited real-world data on the characteristics and outcomes of these patients who are non-transplant eligible and newly diagnosed. And especially in the older, frail patients with comorbidity, we have limited data. So this is a study where it was a retrospective observational study, which included patients from the Flatiron Multiple Myeloma Core Registry who received VRD as first line of treatment between November 1st, 2015 and February 28th, 2021. And the question was to assess the knowledge gaps by evaluating the characteristics and the outcomes of patients with newly diagnosed multiple myeloma who receive VRD as first-line therapy in the US oncology practice outside of the clinical trial setting. Next slide, please. So there were 2,342 patients who were eligible and identified. The median follow-up of these patients were 21 months, and 64% were older than 65 years. About a quarter of these patients were characterized as being older adults who are 75 years of age or older. And the median standard deviation age at the index date was about 67 plus or minus 10 years. Just over half the patients were male, and about 50% of the patients were ISS stage 1 and 2, and about a third of patients had some missing data. ECOG performance status was 0 to 1 in just around 2/3 of the patients, with 22% having missing data. And just under 50% were characterized as frail, and 16% had high-risk cytogenetics, and 10% had renal failure. About 28% of the patients received a stem cell transplant within 1 year of the index date. Next slide, please. So these are the results. Interestingly, the median duration of therapy was only 5.6 months, and the median progression-free survival for the overall study group was 33.2 months, which compares to about 41 months in the long-term follow-up of the SWOG study. So the median PFS was substantially shorter in patients who were older than 75 years of age at 22.8 months. For those patients who were frail, the PFS was 28.7 months, and those with high-risk cytogenetics had 25.1 months, and those who had renal failure had 25.1 months. And if you look at the curves just on the right side of this slide, you can see that at the top slide is all the patients, and the lower, the top curve is all the patients, and the lower three curves are the patients who are elderly, frail, and who have renal failure or high-risk cytogenetics. And those who do particularly poorly are those who are elderly. So in conclusion, the median PFS observed in the real-world setting was shorter than that observed in the SWOG 777 clinical trial. Alternate treatment options with demonstrated efficacy in the older, frail, and transplant-ineligible patients are available and hopefully will be used more broadly in the future. Next slide, please. So how is this in the Canadian perspective? Well, RVD is a standard option that is available in many places in Canada for newly diagnosed multiple myeloma patients who are transplant ineligible. And this current study helps to demonstrate the limitations of the trial data based upon which the approval for this treatment has been made. And it demonstrates that the ability to deliver treatment may be somewhat more difficult and the benefits may be somewhat more attenuated. And of course, a part of the reason why this may be difficult is that in the trials, bortezomib was given twice weekly. And I know that the majority of centers across Canada who have tried to use this regimen are giving bortezomib once weekly. So hopefully it'll be better tolerated than what this recent review has shown. Thank you.
Thank you so much, Kevin. My name is Arleigh McCurdy from Ottawa, and I'll be doing the moderating for this abstract. Next slide, please. So just putting, I think maybe go back one slide, please. Perfect. So thank you. So just putting this into a bit of Canadian context, our standard options over the last approximately decade in Canada have been CyBorD or VMP, sometimes Velcade and dexamethasone or lenalidomide and dexamethasone. And we've looked in the Canadian Myeloma Research Group database at these regimens and have seen that on average, we're getting about 20 months up to 28 months for Lendex in the frontline setting. And that was very, very comparable actually to what was seen in the randomized trials that led to the approvals of these agents. More recently, in the last couple of years, VRD has been available in many jurisdictions in Canada. And as Kevin mentioned, we tend to use an RVD light approach with weekly subcutaneous bortezomib, really to lessen the neuropathic side effects that can happen with intravenous Velcade. And we do have a subsequent CMRG database analysis underway looking at the real world experience in Canada using VRD. We can recognize, though, that these options, particularly 20 to 28 months, are suboptimal for newly diagnosed patients and better options are needed. Next slide, please. More recently, the combination of daratumumab, lenalidomide, and dexamethasone has been shown to be very effective in this setting with unprecedented PFS of close to 5 years, which is certainly improved from what we've seen in the SWOG 077 trial and in any real-world analysis of VRD or the older regimens such as CyBorD or RD. This currently is not available or reimbursed in Canada, but we do feel that this is imperative for Canadian patients. We are trying to improve on our current standard of care right now. We have a CMRG trial coming up looking at iberdomide, which is a new cell mod, which will replace lenalidomide in the RVD combination in this trial, and we're hoping for excellent results with that. There'll be more on cell mods a bit later in this session, and also new approaches of earlier introduction of CAR-T therapy, again, more in a few minutes. And so hopefully we'll see some improvements for these patients in the very near future. Just closing on the abstract that you presented, Kevin, with knowing that in many jurisdictions we can access RVD and don't yet have newer options such as daratumumab incorporated into frontline, do you think that RVD should be the standard for Canadian patients currently?
Thank you, Arleigh, for that question. I think that it is one of the standards and should remain one of the standards. but obviously we're waiting for a better standard that will hopefully be funded in the future. And as you pointed out, DRD is extremely well tolerated and has significant improvement in survival, progression-free, and overall. And a lot of us have much experience in giving that triplet with daratumab. And I think a lot of us do recognize that it is much better tolerated than the combination of RVD in the long run. So I do think the RVD in the frontline setting for transplant-ineligible patients is really kind of a temporary standard, which will likely be overcome by DRD when that is subsequently approved.
Thanks so much, Kevin. We're now going to move on to some of the new treatment developments or new technologies, starting with CAR-T cell therapy. And I'll pass it over to my friend Richard LeBlanc for our first presentation. You're on mute, Richard, sorry.
Oh, hello, I'm Dr. Richard LeBlanc, a hematologist at Maisonneuve-Rosemont Hospital in Montreal. I will present a phase 2 trial on BB21217, I will call B217, a BCMA-targeted CAR-T cell therapy for relapsed and refractory myeloma patient that was presented at ASH by Dr. Nupur Rajay. Next slide. B217 is the same CAR-T molecule as Ide-cel, which has already received its approbation from Health Canada. However, B217 is cultured with a PI3 kinase inhibitor to enrich the T cells displaying a memory-like phenotype. And these CAR-T cells might persist and function for a longer period of time, which can be a limitation for many CAR-T products. The hypothesis being that persistence of functional CAR-T may be one determinant factor of duration of response. This is a phase 1 trial with a standard design with an escalation phase followed by an expansion phase with the maximum tolerated dose. Patients were enrolled, get their leukapheresis for CAR-T manufacturing, receive the standard lymphodepletion, and then receive the CAR-T product. Dose was started at 150 million cells and increased progressively to 300 million cells to 450 million cells. That was the recommended phase 2 dose. Primary endpoints were adverse events, dose-limiting toxicity, and secondary endpoints were standard with progression-free survival, overall survival, MRD, in addition to CAR-T expansion and persistence. Next slide, please. Eligibility criteria included relapse and refractory myeloma patients with at least 3 prior lines of treatment, previously exposed to IMiD, PI, proteasome inhibitors. In the expansion phase, prior use of anti-CD38 monoclonal antibody and refractory to the last line of therapy was required. As you can see on the slide, participating patients were heavily pretreated with 6 prior lines of therapy, with 69% of patients triple-class refractory. Next slide. In terms of safety, cytopenia was common and mostly grade 3 and 4, with a long median time to recovery of 2.1 months for neutropenia and 3.2 months for thrombocytopenia. Infection of grade 3 or more was reported in 29% of patients with 1 death. Cytokine release syndrome, the CRS, was common in 85% of patients at the recommended phase 2 dose with 2 deaths. 4% of this population. The median time to onset was 2 days, and the duration of CRS was 4 days. Neurotoxicity was reported in 11%, mostly grade 1 and 2, with only 2% of grade 3 at the recommended phase 2 dose. At this dose, as you can see on the left lower figure, the overall response rate was achieved in 74% of patients, with 39% of patients with complete response and 65% with VGPR, very good partial response or better. For those achieving a complete response, 90% of patients achieve MRD negativity, meaning a very deep response. The duration of response was obviously dose dependent, with a median for the whole cohort of almost 24 months, which the median was not reached for the higher doses. At the recommended phase 2 dose, a median progression-free survival was 18 months. As we could expect, memory-like phenotype in both CD4 and CD8 T cells were associated with a better duration of response. In terms of persistence, detectable CAR-T were present in 16 out of 21 evaluable patients at 12 months and 6 out of 8 patients at 24 months. Next slide. In practice, CAR-T, although just one unique administration, is associated with a high resource use burden, including leukapheresis step, hospitalization, expertise needed from academic centers for a few weeks or months after the administration because of CRS, neurotoxicity, or prolonged severe cytopenia. However, there is no doubt that this is a very effective treatment and safe, at least in the context of heavily pretreated patients. An earlier use is expected within the next few years, and with PI3 kinase inhibitor to enrich the T cells to display a memory-like phenotype seems beneficial when we compare the result of B21-7 to the result of KarMMa. For example, the PFS, the progression-free survival in KarMMa was about 12.1 months versus 18 months at the highest dose for B21-7. That could be related to the memory-like phenotype of the product and its persistence over time. It's a very interesting product and very promising that could be more effective than ide-cel, we will see. Next slide for the next presenter.
Thank you, Richard. I'm Darrell White. I'm a hematologist in Halifax, and I'm going to present a similar abstract as Dr. LeBlanc. This is abstract 549, which is updated results from CARTITUDE-1, which was an early study of cilta-cel, a different agent than Dr. LeBlanc had presented. It's still a B-cell maturation antigen-directed CAR-T therapy in patients with relapsed and refractory myeloma, and this was presented at the ASH meeting by Dr. Thomas Martin. Much of the detail is similar to what Dr. LeBlanc just presented. Next slide, please. So by way of overview, cilta-cel is a different CAR-T product with two BCMA or B-cell maturation antigen targeting single domain antibodies that demonstrated early, deep, and durable responses in this population of patients in the CARTITUDE-1 study, at least the portion that's been published thus far in the Lancet this year. After median follow-up of 12.4 months, the overall response rate was 97%. The stringent complete remission rate was 67%, and the 12-month progression-free survival and overall survival were 77% and 89% respectively. The question here really relates to an updated look at the data, now at a median of 24 months. The design is an open label, multi-center phase 1b/2 study. Patients, similar to Dr. LeBlanc's study, had at least 3 prior lines of therapy, including a proteasome inhibitor and an IMiD, and had received a PI, IMiD, and an anti-CD38 monoclonal antibody. The procedure itself is similar. The target dose, however, is different. The actual CAR-T procedure varies slightly by product, at least in terms of dosing. The endpoints here were to look at safety, confirm the recommended phase 2 dosing, and to have a look at efficacy as well. Next slide, please. And these are the high-level endpoints of this study. So on the left panel is progression-free survival. Both curves are very good. The blue curve is all patients enrolled, and the green curve is the 80 of the total 97 patients who achieved a stringent complete remission. And you can see that at the 24-month point, 71% of patients are still in remission. Overall survival on the right-hand side, again, looks very good for this population of patients. At the 2-year point, 74% of patients are alive. Next slide, please. When you look at those patients with the deepest response, so now looking at specifically the patients who sustained minimal residual disease negativity at least 6 months in the light blue line, or at least 12 months in the orange line, versus all patients in the darker blue line. On the left panel, you can see progression-free survival is clearly best for those patients with sustained MRD negativity. And on the right panel, overall survival is 100% at the 2-year point for those patients with the deepest remissions. Next slide. So in summary, at a 24-month time point, a single cilta-cel infusion led to early, deep, and durable responses in these heavily pretreated patients with myeloma. Overall response rate is approaching 100%. The median progression-free survival is still not reached, but at the 2-year point is 60.5%, and 71% for those patients achieving a stringent complete remission. Cilta-cel demonstrated a manageable safety profile, no new safety signals. The safety itself I didn't review, but it was similar to Dr. LeBlanc's presentation. Further investigations are underway looking at this product in earlier lines of therapy, has been alluded already. Next slide, please. So applicability to Canadian practice, this product is not yet Health Canada approved or available in Canada. It may become available in time on the basis of data like this, with longer progression-free survival versus ide-cel, which is the product that's Health Canada approved currently, although for the most part not available. The cilta-cel may actually be the preferable agent at this point in terms of the Canadian market. There are differences, however. The cytokine release syndrome is somewhat delayed, and there are potentially longer-term neurological side effects that need to be considered, and we'll have further information as time goes on. And as with cilta-cel, there may actually be manufacturing limitations for our potential Canadian market. Next slide, please.
Thank you to our speakers. I think we are in the era of this new cellular treatment, and we heard a lot in the past about the KarMMa trial, the BB2121, that is the first approved CAR-T cell for myeloma in Canada and elsewhere. It's not funded in Canada, but it did establish the proof of principle that this platform could even be effective in myeloma, although there was a problem with the CAR-T cells fizzling out over time. Nevertheless, in the original study, a third of the patients achieved a deep remission, and those patients had a duration of remission of 21.5 months. So at ASH, we heard a number of ways to improve the outcome of CAR-T cells. You've already heard about the BB21217 from Richard. You can target 2 different antigens, or you can use it earlier in the disease. And I think we're all very excited in more advanced disease about the results with cilta-cel. And one of the other points to mention to the audience is Canadian centers have the ability to manufacture their own CAR-T cells. And given the cost of the industry products, we think that academic trials in myeloma will be important to allow a wider availability of this in a system like ours with financial constraints. Next slide, please. So it's interesting that the trial that will be opening across Canada at the sites listed, and it's just opened at Princess Margaret, is for transplant-ineligible patients. And the trial design for CARTITUDE-5 is shown here for your interest. Patients receive one of the standard inductions we've already heard about, RVD, then are randomized to either 2 more cycles of RD and then RD maintenance, or They go on to have their lymphocytes collected. And to get around the problem we've had with the delay in processing these cells, which may take 4 or 5 weeks, RVD is given for 2 bridging cycles to prevent recurrence. Then patients receive high-dose therapy for lymphodepletion and reinfusion of their CAR-T cells. Next slide, please. So before moving on to the next topic, I would like to ask our 2 CAR-T experts their thoughts on assuming next year we have an option for a transplant-ineligible patient for DaraRVD or CARTITUDE-5. How will you decide when a patient is sitting in front of you? Because this may be a Canadian reality.
It's a very important and very hard question, Donna. We know that DRD is very effective treatment with a median PFS not reached yet, but over 60 months in the first-line treatment in MAIA trial. So it might be hard to select CARTITUDE-5 versus DRD, but half of the patient in CARTITUDE-5 will receive the CAR-T treatment, which is one of the most promising treatment, which may have a curative effect, at least in some patients. So we will see.
I agree with Richard. I think one of the things that may tip the balance if I were discussing with a patient potentially enrolling in the study versus hopefully what our standard will be, which will be a DRD, may in fact be the fact that with the CAR-T treatment, one goes through an intense, brief period of treatment and then hopefully has a long remission without treatment versus the continuous treatment that our transplant-ineligible patients are more used to.
Thank you very much. I think we'll move on to the next new and exciting immune platform. Michael?
Thank you, Donna. So it's a paper that I presented. It's called Magnetism-1. It's a study of a bispecific molecule called Elrantamab. So it's a molecule that binds BCMA, B-cell maturation antigen, on one side and CD3 on T cells on the other. And this is for patients with multiply relapsed refractory multiple myeloma. Next slide. So the background is, as I've said, a bispecific antibody that really redirects the T cells to the myeloma cells. And Magnetism-1 is the initial study of and it's a multi-part phase 1 trial that aims to evaluate first the safety, then the pharmacokinetics and dynamics, and finally the efficacy of patients in myeloma. Next. So the trial was designed with a stepwise increase in dose of this molecule from 80 all the way to 1,000 microgram per kilogram. And the initial treatments were given intravenously, but quickly switched to subcutaneous, for the most part weekly. And we'll talk about that in a second. And in this particular presentation, we will focus on a dose escalation part with focus on the efficacious dose above and including 215 microgram per kilogram. So in the dose escalation segment, 30 patients were given from 80 to 1,000 microgram per kilogram weekly. In the priming cohort, which was aimed at attenuating one of the adverse events, the cytokine release syndrome, 20 patients were given a single priming dose of 600 microgram per kilogram, followed by a week later a full dose of 1,000 microgram per kilogram given either weekly or Q2 weeks, depending on where the patient was on that schema. Finally, 15 patients were then put onto an expansion cohort where a single priming dose of 44 milligrams was followed a week later by a full dose of 76 milligrams, which roughly represents 1,000 microgram per kilogram. And this was given with pre-medications on both the the initial priming dose and the first full dose and nothing after that. The endpoints are really safety, so the treatment emergent adverse events with special attention to the cytokine release syndrome. Efficacy was determined by standard IMWG criteria, and these were verified responses. And MRD was assessed by next generation, not flow, it's an error, next generation sequencing at 10 to the minus 5. And then some PK/PD were done as well. Next. So these are the baseline patient characteristics of the 55 patients that received the efficacious dose of 215 and above. And what's good to note here is that virtually all, 98%, were triple class exposed. And of those, or of the cohort, almost all of them, over 90%, were triple class refractory. And all of them, of course, have seen daratumumab, for example. Of note, just over 20% of patients had seen previous BCMA targeted therapies, such as the antibody drug conjugates like belemaf or CAR-T, and some both, in fact. Next. So with regards to the CRS, I'm giving you just one little table that shows you the incidence of cytokine release syndrome, which was seen in virtually all patients initially, about 100%, and that's without pre-medication. So both in the dose escalation, where they got the full dose up front, and the priming cohort, which got a smaller priming dose prior to the full dose. But all of these are grade 1 and 2 and nothing beyond. The duration median for this is 4 days for dose escalation without priming, and a reduction in the priming in the patients who got a small priming dose of 3 days, with a median that ranged from 2 to 7 days. So definitely a decrease. In the expansion cohort that saw pre-medications, and those pre-medications included diphenhydramine, dexamethasone about 20 milligrams, and acetaminophen. The overall incidence was reduced down to about 66%, and the duration remained on the lower side with a range of 1 to 4. Next slide. So with regards to the efficacy, so I'm going to show you just one cohort, I believe, one cohort, which is the increasing dose levels without priming. And in this cohort, above 250 micrograms per kilogram, we're seeing very good responses. In fact, approximately 70% of patients have an overall response. These responses were deep and were lasting. To date, the cutoff of data cutoff of November, over at least 2 patients in this cohort that achieved a CR and VGPR or better are at 19 and 21 months and going. Of interest, 75% of patients that were evaluable, who had BCMA-directed therapies prior, responded. Really the same rate that we're seeing in those that were BCMA therapy naive. And 100% of patients that were evaluable for MRD assessment were MRD negative. Next slide. So this proves that monotherapy has a manageable safety profile, that the strategy of priming and especially pre-medication reduces the incidence and duration of cytokine release syndrome. The overall response rate, as I've said, is about 70% at the recommended dose of 1,000 microgram per kilogram. And of real interest is patients with prior BCMA-directed therapies, a similar proportion responded, over 70%. Next slide. Right. So while the addition of anti-CD38, is this mine? No, this doesn't belong there. I apologize. Next slide. So now I'm going to introduce Dr. Song, who will present the next T-cell engager therapy.
Thank you, Michael. That was a great summary of your abstract. I will be speaking on abstract 896, which is titled Updated Results from MajesTEC-1 Phase 1/2 study of teclistamab, a B-cell maturation antigen, CD3 bispecific antibody in relapse refractory multiple myeloma. This was presented by Dr. Philippe Moreau on behalf of the MajesTEC-1 investigators. Next slide, please. So teclistamab is a T-cell redirecting bispecific antibody that targets both BCMA and CD3 receptors, similar to the previous bispecific antibody that Dr. Sebag spoke about. So the results from the phase 1 study indicated that teclistamab is well tolerated at the and a recommended phase 2 dose has been made. And so at the phase 1 dose, an overall response rate of 65% with very good partial remission rates of 58% in 40 patients at a median of 6.1 months follow-up. So the study design is that this is MajesTEC-1, which is an ongoing phase 1/2 study in patients with heavily pretreated relapse refractory multiple myeloma. And the endpoint was to report for the first time the initial data from the phase 2 portion of the study and update the results for the phase 1 patients. Next slide. So key study details are patients with multiple myeloma had to be exposed to a proteasome inhibitor, immunomodulatory drug, and an anti-CD38 antibody. The primary objectives in the phase 1s were to identify the recommended phase 2 dose and to characterize the safety and tolerability of teclistamab as the recommended phase 2 dose. The primary objective in the phase 2 part of the study is to evaluate the efficacy of teclistamab. Patients treated at the phase 2 dose received a weekly dose of subcutaneous teclistamab at 1,500 micrograms per kilogram, following step-up doses of 60 and 300 micrograms per kilogram. Next slide, please. So they presented on 165 patients who were treated, with 40 in the phase 1 portion and 125 in the phase 2 portion. The patients had received a median of 5 prior lines of therapy, and 100% were triple class exposed, 70% were penta-drug exposed, and 77% were triple class refractory, with 30% being penta-drug refractory. The most common non-hematological AEs were CRS, which occurred in 72% of the patients. Grade 2 or more occurred in 32.7% of the patients. But the median duration of CRS was only 2 days, with a range being between 1 to 9 days. Neurotoxicity occurred in 13% of the patients, but in the majority of patients, it was headaches, and only in 3% of the patients did ICANS occur, and this was all reversible. The most common hematological adverse events were neutropenia at about 53%, anemia 41%, and thrombocytopenia in about 33%. So teclistamab exposure at the recommended phase 2 dose was sustained across the dosing interval and exceeded the target exposure levels. The pharmacodynamic data for the phase 1/2 patients treated at this dose showed induction of pro-inflammatory cytokines and T-cell activation consistent with teclistamab's mechanism of action. Next slide. At a median follow-up of 7.8 months, the overall response rate was 62%, with 28.7% of patients having CR or better. The MRD was negative in 24.7% at 10 to the minus 5, and importantly, the time to response was a very short 1.2 months. Responses deepened over time and remained durable, and median duration of response has not been reached yet. At 6 months, the duration of response is 90%, and the progression-free survival at 6 months is 64.4%. So in conclusion, teclistamab is efficacious and tolerable in patients with triple-class exposed relapse refractory multiple myeloma, and 62% overall response rate was durable and deepened over time. And importantly, this drug is a promising off-the-shelf T-cell redirecting therapy against BCMA. Next slide. So the Canadian perspective on the 2 bispecific antibodies that were presented by Dr. Sebag and I are that currently there are a number of different anti-BCMA treatment modalities are currently being investigated. CAR-T cell therapy is currently the only modality that is approved by Health Canada, but not available due to the high costs and the resource utilization, including hospitalization and infrastructure needs. CAR-T cell therapies are personalized therapies which require manufacturing of the patient's own cells. But anti-BCMA bispecific antibody treatments are of great interest as it is off the shelf and can be delivered relatively quickly, and therefore has a significant convenience advantage. The study demonstrates the efficacy, the durability of response, and the manageable toxicity profile of this bispecific antibody. Thank you.
Alrighty, we're going to switch gears quickly and talk about antibody drug conjugate. And I'm very happy to summarize this study as it's a CMRG study, the ALGONQUIN study, and was presented by Dr. Darrell of the Princess Margaret Cancer Center. This is just the results of the first part of the ALGONQUIN study, which is a phase 1/2 study looking at Elrantamab, which is the BCMA piece of the antibody attached to the toxin in combination with pomalidomide and dexamethasone for treatment of relapsed refractory myeloma. Next slide, please. The schema here is seen here, and part one is really to look at trying to find the right dose. You can see the multiple cohorts, which is looking at different doses of Elrantamab, and then with the dose trying to look at different administration schedules, all combined with pomalidomide and dexamethasone. This study reports the updated tolerability and efficacy data for all the patients treated through cohort 1 through 3B. Next slide, please. So in terms of the demographics, you can see as of October, 56 patients were enrolled in between all of the different cohorts. The median age was 64 and the median prior lines of therapy was 2.5, and consistent with a lot of the other inclusion criteria, 100% were PI and LEN exposed, and also a heavily refractory patient population. Next slide, please. So as you can see here, 54 patients were evaluable with a median follow-up of 11 months. And across all of the dosing cohorts, the overall response rates and then VGPR better were 88.9 and 72.2 together. You can see that in the graphs below, those who received belantamab at 2.5 with an alternate dosing schedule rather than weekly have shorter follow-up. Next slide, please. Really what they wanted to look at was a safety overview. What I wanted to point out here is that serious adverse events were observed in 50% of patients, with one fatal event due to respiratory distress syndrome. In terms of treatment AEs, they were reported by a significant number of patients. The most frequent grade 3 or more event of non-ocular AEs were neutropenia and thrombocytopenia, but the important one we are concerned about are the keratopathy and blurred vision. And you can see the lower the dose, the less severe the keratopathy and blurred vision, but this does come at the expense of efficacy. Next slide, please. So in conclusion, it demonstrates somewhat of a manageable safety profile when you combine belemaf with pomalidomide and dexamethasone, and has been consistent with the known safety profiles of all three of those drugs. There is the corneal events, the keratopathy and blurred vision, which is not insignificant. And I think that while the recommended phase 2 dose is 2.5 Q8, we'll have to see what happens in part 2 and the phase 2 piece. So again, I think this drug combination is efficacious, especially in those triple class exposed and refractory patients, but the ophthalmologic toxicity continues to be concerning. And hopefully we'll be able to find kind of that sweet spot between the right dose and administration schedule that balances both efficacy and safety. Next slide, please.
Thanks so much to the three speakers. I just want to take a moment to acknowledge that it's 3:01 and we are at time, and we certainly value everybody's time this afternoon for tuning in with us. If you are able to stick around for about 10 more minutes, we have 2 quick abstracts on the new cell mods and we'll be wrapping up. If you're not able to stick around, we really want to thank you for participating with us We also wanted to make sure that a huge thank you goes out to our patients and their caregivers who really make all of this progress possible. And we also wanted to thank the supporters and donors of CMRG and to recognize that all of those contributions have allowed over 400 patients in Canada to have access to these novel therapies that they wouldn't otherwise have access to, and really keeps us motivated as a research group to keep working towards better access for patients and better science in Canada. And so giant thank you to everyone. And for those of you who are able to stick around, I'm just going to quickly summarize this in the Canadian context and move on to the cell mods to finish off the session today. So as our speakers mentioned, the bispecific T-cell engager is really exciting new agents, similar with respect to mechanism of engaging T-cells as CAR-T cell therapy, but some advantages, typically milder side effects, no need for processing time, and some of them can be given as a subcutaneous infusion. There's multiple different targets, and this is really exciting because it raises the question of using them in combination or using them in sequence. Next slide, please. There are many Canadian centers that are participating in industry bispecific studies currently. And our group has a planned study coming up in partnership with the EMN, the European group, looking at teclistamab, which is a bispecific just presented in combination with lenalidomide maintenance after transplant. So it's a very exciting opportunity for Canada and our patients. Next slide, please. The antibody drug conjugates we lump in together because they tend to be anti-BCMA agents. Belantamab mafodotin is the one that we use most commonly. We have many centers in Canada doing the industry DREAM series of trials that incorporate that agent. And then as Dr. Stakiw just presented, the ALGONQUIN trial, which was an awesome opportunity in Canada, allowed us to find the pivotal dose, which will be carried going forward internationally for this combination, and allowed access to our patients of a drug that there really is no other potential access for, and an important immunotherapeutic option. So with that, I'm going to turn it over to our last two speakers, and Dr. LeBlanc is again going to chat with us about one of the cell mods.
So I will talk on a phase 2 trial on CC220 called Iber. I will call Iber for relapse and refractory myeloma patient in combination with DEX that was presented by Dr. Sagar-Lonial. Iber is a novel class of drug called cell mod, a kind of next generation and more potent IMiD agent. Indeed, it has enhanced tumoricidal and immunostimulatory effect compared with IMiD. It is also active in lenalidomide and pomalidomide resistant cell lines. And in vitro, there is a synergy of its anti-myeloma activity with other drugs such as dexamethasone. So this trial is a phase 1 and 2 study on iberdomide, alone or in combination with dex, bortezomib, and daratumumab, but this specific abstract focused on 2 cohorts, D and I, in combination with dexamethasone at the recommended phase 2 dose of 1.6 milligram orally daily, 21 days out of 28. Eligibility criteria, as you can see on this slide, include relapse and refractory. The previous slide, please. So the eligibility criteria include relapse and refractory myeloma with 3 prior lines of treatment or more. Cohort D was refractory to proteasome inhibitor, to IMiD and anti-CD38 monoclonal antibody, and cohort I was previously exposed to anti-BCMA therapy. Primary endpoint was efficacy in terms of overall response rate with standard secondary endpoints, including safety. Next slide. As you can see on this slide, participating patient, 107 patients in cohort D and 26 patients in cohort I were heavily pretreated with 6 and 7 prior lines of therapy, triple class refractory in 97% of patients in cohort D and 81% of patients in cohort I. Next slide. On the upper left, you can see the overall response rate that was reached in 25 to 26% of patients, with few patients with very good partial response or better. The median duration of response was around 7 months. And on the lower left, you can see the median progression-free survival that was 3 months. On the lower right figure, you can see the median overall survival that was 11.2 months, which was obviously longer for responders. In terms of toxicity, grade 3 or 4 were mostly hematologic toxicity. Non-hematologic toxicities included fatigue, rash, diarrhea, and infection. So authors concluded to clinically meaningful and durable response with a safe profile of toxicity. Next slide. In practice, this is an easy medication to administer since it is oral. It is more potent than IMiDs since refractory patients may achieve a response, even if they are refractory to lenalidomide or pomalidomide. But while it is considered a new class of drug called cell mod, in terms of toxicity, Iber is really similar to IMiD with the same kind of toxicity. Obviously, in this heavily pretreated population, achieving a response rate of 20% or over in this trial, 25 to 26% of patients, with a median duration of response of 7 months combined with DEX is significant. With a similar mechanism of action to IMiDs, we could expect cell mode to replace IMiD eventually with its earlier use in its development. More potent cell mod are in development and will certainly be interesting to follow. And the next abstract will be presented by Dr. Darrell White on another cell mode.
Thanks, Richard. So this is a similar drug. It's the more potent related drug that Richard referred to. So this is abstract 2731 concerning a drug at this point, which doesn't have a name, just letters and numbers, CC92480. So this is also a cell mod, which is being used here in combination with dexamethasone and bortezomib or Velcade in patients with relapse refractory myeloma. And this is these are results from the phase 1/2 study presented at the ASH meeting by Dr. Paul Richardson. This is a study that many of our Canadian centers have participated in, including several of us on this call today. Next slide, please. I won't spend much time in the background except to say that this is a very similar agent to the one that Richard just presented. The effects of 92480 in combination with standard treatments in relapse refractory myeloma are being evaluated in this ongoing trial. And it's quite a good trial. And again, we're fortunate to have the opportunity to participate in Canada. The question really is, what is the efficacy and safety of this drug in combination with various backbone agents, in this case, bortezomib and dexamethasone. So this is an open label study. Eligible patients had 2 to 4 prior lines of therapy, so not as heavily pretreated as the iberdomide study that Richard just presented. 3 dose levels of the 480 drug were combined with bortezomib and dexamethasone, and each treatment cycle was 21 days. The endpoints considered were primarily the dose that might move on to further expansion. Next slide, please. 19 patients were treated in this cohort that's being described. Median age was 66. Of 12 evaluable patients, 7 had high-risk cytogenetics. 4 of 19 had extramedullary plasmacytoma, so relatively high-risk patients. Median prior lines of therapy were 3. 79% approximately were IMiD refractory, 36.7% were anti-CD38 refractory, and 21% had triple class refractory background. The results from these 19 patients are shown here in the 3 figures. So figure A on the left demonstrates deep responses with an overall response rate of 73%. The figure B in the middle is demonstrating that at the various dose levels of 0.3, 0.6, and 1 milligram, you can see that some patients had deep responses many of which are ongoing, and the details of the patients are outlined there as well. And then in terms of the panel C on the right, the main point here is that the toxicity, as Richard described, is very similar to what we're experienced with the IMiDs. So mainly hematologic, which we can deal with, and the rest were relatively minor low-grade toxicities. Next slide. So in summary, 480 in combination with bortezomib and dexamethasone appears to be safe, well tolerated. The efficacy, I think, is quite interesting, exciting, with an overall response rate of 73%. There are other data shown in this abstract that demonstrate that the pharmacodynamic and immune stimulatory effects are as they should be, as expected. Likewise with the pharmacokinetic and pharmacodynamics data. The results certainly support further development, and that's ongoing currently. Next slide. So in terms of Canadian applicability, these results are early, but certainly bear watching. The deep and sometimes durable responses were demonstrated in these some high risk and heavily pretreated patients. The combination with bortezomib and other partners, as I said, is ongoing. There's no current applicability of this drug in terms of standard use, but I think it's coming. And as Richard said, I think the debate will be what place does it take in terms of our sequencing of therapy. Next slide.
Thank you, Richard. In the commentary, I think we are impressed with the activity of these cell mods, and we're now seeing the spectrum from very sophisticated cellular therapy to a pill that can achieve, in some patients, spectacular results. And the reason is explained here. I think for the Canadian environment, these oral drugs are extremely attractive. We don't have to have fancy resources added to our current clinics. They're outpatient. And I think as we see these agents combined with bortezomib, Darrell, and even the new BiTes, and perhaps even with CAR-T cells, we can look forward to some really unprecedented results over the next few years. Next slide, please. I think we've already alluded to the fact that we will be using the Iber BiTE in an IBD light. That's sort of like RVD light. The randomized trial that will study Iber BD with RVD to get the drug approved in various countries has to use twice weekly bortezomib, and that's going to limit tolerance. And we have been allowed in Canada through CMRG to give it the way we think will be better for patients and retain the efficacy. And this may be very informative for the international care providers and beneficial to patients that they won't have to have the neurotoxicity. I think our organization has expressed considerable interest in conducting further trials with these drugs, particularly CC480. So we are in very early but enthusiastic negotiations with the sponsor to further introduce this agent into our Canadian patients. So the question I have for our two speakers, and thank you for the audience for staying on, is, are lenalidomide and pomalidomide dead? Are they going to become history? And if you have a crystal ball, what do you think will happen as these newer, more potent but related agents come into practice?
It's a good question. And until the time myeloma will be cured, all new classes of drugs with a potent effect against myeloma are certainly more than welcome. Again, in some ways, with a similar mechanism of action to IMiD, we can certainly expect that cell mode will replace IMiD eventually with its earlier use and its development in combinations with other agents. So we will see, but it might take years.
Yeah, and I don't have much to add to that. I think these are exciting drugs that, you know, again, we've had the fortune of being able to use in Canada on study. They are relatively easy to use and relatively low in terms of toxicity, and whether they fit into later lines. Certainly, I think the trials that we're hearing of and signing up to hopefully participate in are moving them closer to frontline.
Thank you. So I'm going to turn things over to Arleigh, who will conclude the meeting. And please accept my personal appreciation for your participation and persistence in staying past our 1 hour.
Thanks very much, Donna, and thanks again to all the speakers and to everyone who joined in today. We especially want to thank, as I mentioned before, our patients and their caregivers, and gratitude to our supporters and donors. I've been looking at the chat. I don't see any questions coming in, so I'll pop back once more. There is about a 15-second live delay, so we'll see if we have any questions. If you have a question and are not able to put it in today, please look up our website, cmrg.ca. You can contact us through there and we can try to answer your question about anything that was presented today. And if you are interested in supporting CMRG, there's an opportunity through the link at the bottom of this page, as well as on our website. And so I'll just take one more look at the chat here and see if there's any burning questions for our panelists today. And I don't see any questions coming in. So with that, we will conclude. Thank you everybody for your time, and please stay safe and have a happy holiday season.
Thank you, everyone.
Thank you. Bye-bye.
Thank you.